السلام عليكم.
وعليكم السلام، أتمنى لك يوما جميلا. إذا احتجت أي شيء أنا موجود هنا دائما.
Could you speak in English?
Of course, I'll switch back to English. If there's anything else you need, just let me know.
Okay. I need your help in to tell me
Absolutely.
about infantile hypertrophic pyloric stenosis.
Sure thing. Infantile hypertrophic pyloric stenosis is a condition that affects infants, usually appearing in the first few weeks of life. It involves the thickening of the pyloric muscle, which is at the lower end of the stomach. This thickening narrows the pyloric canal and blocks food from passing into the small intestine. This leads to symptoms like projectile vomiting, dehydration, and poor weight gain. It's more common in male infants and typically shows up within the first couple of months. Diagnosis is usually confirmed with an ultrasound, and treatment often involves a surgical procedure called pyloromyotomy. The prognosis is generally excellent once it's treated. If you'd like more details on any specific aspect, just let me know.
Okay. What about epidemiology and risk factor?
Sure. In terms of epidemiology, infantile hypertrophic pyloric stenosis is more common in male infants with a ratio of about 4 to 1 compared to females. It typically appears between 2 and 8 weeks of age, and it's quite rare after about 3 months. It's also more frequently seen in firstborn children. And for risk factors, genetics play a significant role. So having a family history can increase the likelihood. Additionally, exposure to certain antibiotics, particularly macrolides like erythromycin in early life, has been linked to an increased risk. Environmental factors also play a part, with formula feeding sometimes being associated with a higher incidence compared to breastfeeding. If you'd like more details on any of these points, just let me know.
Okay, I need about to know about clinical features. How can the baby came to clinic or ER?
Absolutely. When it comes to the clinical features, the classic presentation usually involves a few key signs. One, projectile vomiting. One of the hallmark symptoms is forceful, non-bilious vomiting that usually occurs shortly after feeding. This vomiting is typically quite forceful and can propel the milk several feet. Two, hunger after vomiting. Babies often appear hungry even after they vomited, so they may want to feed again soon after. Three, dehydration due to the persistent vomiting. Dehydration can set in. Signs include dry mouth, sunken eyes, reduced urine output, and lethargy. For palpable olive, during a physical exam, a doctor might feel a firm, movable mass in the upper right quadrant of the abdomen, which is the hypertrophied pylorus. Five, visible peristalsis. Sometimes you can see waves of peristalsis moving across the baby's abdomen from left to right, as the stomach tries to push food through the pylorus. Six, poor weight gain. Because the baby isn't absorbing nutrients properly, they may not gain weight as expected, and this can lead to failure to thrive. These clinical features usually prompt parents to bring the baby to the clinic, especially when the vomiting is persistent and severe. If you'd like to know more or have any specific questions, just let me know.
Okay, what about laboratory finding?
Definitely. In terms of laboratory findings for infantile hypertrophic pyloric stenosis, the key features usually revolve around metabolic changes due to the persistent vomiting. One, metabolic alkalosis. The most common finding is a metabolic alkalosis, which happens because of the loss of stomach acid through vomiting. This leads to an elevated blood pH and bicarbonate levels. Two, hypochloremia. There's typically a low chloride level in the blood because the stomach acid, which contains chloride, is lost through vomiting. Three, hypokalemia. Potassium levels are often low as well due to the loss of potassium in the gastric fluids and also from the kidney's response to the alkalosis. Four, paradoxical aciduria. In some cases, especially as the condition progresses, the kidneys excrete acid inappropriately, leading to aciduria despite the overall alkalosis. These lab findings help confirm the diagnosis and guide the management, especially when it comes to correcting dehydration and electrolyte imbalances before surgical intervention. If you need any more details or have other questions,
No,
just let me know.
just only I need diagnosis. How can diagnose the case or disease?
Absolutely. Diagnosing infantile hypertrophic pyloric stenosis primarily involves clinical evaluation and imaging. One clinical assessment, the doctor will look for the characteristic signs like projectile vomiting, the palpable olive in the abdomen, and the baby's overall symptoms. Two, ultrasound. This is the gold standard for diagnosis. An abdominal ultrasound will typically show a thickened pyloric muscle, generally a pyloric muscle thickness of 3 to 4 millimeters or more, and a pyloric channel length of 14 to 18 millimeters confirms the diagnosis. 3, upper GI series. If the ultrasound is inconclusive, an upper GI contrast study can be performed. This might show the classic string sign where the narrowed pyloric channel is evident. 4, laboratory tests. While not used for diagnosis alone, labs can help support the findings. They often show metabolic alkalosis, hypochloremia, and hypokalemia, as we discussed earlier. By combining the clinical signs with imaging, doctors can confidently diagnose the condition. If you need more details or have other questions, just let me know.
Okay, what about initial management?
Sure, the initial management of infantile hypertrophic pyloric stenosis focuses on stabilizing the baby before any surgical intervention. 1, fluid resuscitation. The first step is to correct dehydration. This is usually done with intravenous fluids, typically normal saline, to restore the baby's fluid balance and improve their circulation. 2, electrolyte correction. As part of fluid resuscitation, it's crucial to correct electrolyte imbalances. This includes replenishing potassium and chloride. Potassium is usually added to the IV fluids once the baby has adequate urine output to avoid complications. 3, nasogastric decompression. In cases where the baby has significant vomiting and gastric distension, a nasogastric tube may be inserted to help decompress the stomach and reduce vomiting. 4, monitoring throughout this process. It's important to monitor the baby's vital signs, urine output, and electrolyte levels to ensure that everything is stabilizing properly. The main goal is to stabilize the baby's hydration and electrolyte balance before moving on to the definitive surgical treatment, which is the pyloromyotomy. If you need more details or have any other questions, just let me know.
Yeah, what about prognosis?
The prognosis for infantile hypertrophic pyloric stenosis is generally excellent. Once the condition is diagnosed and treated, usually with a pyloromyotomy, babies recover very well. Most infants experience immediate relief from symptoms after surgery and can start feeding within a few hours post-op. They usually go on to have normal growth and development without any long-term complications. In general, once the baby is stabilized and the surgery is performed, the outlook is very positive, and they can typically return to normal feeding and activity pretty quickly. If you have any more questions or need further details, just let me know.
Did the patient need post-operative care?
Yes, absolutely. Post-operative care is important to ensure smooth recovery. After the pyloromyotomy, the baby will typically be monitored closely for any signs of complications like infection or issues with feeding. Usually feeding is started a few hours after surgery, beginning with small clear liquids and then gradually progressing to breast milk or formula. It's important to start slow and monitor for any vomiting or discomfort. 2, hydration and electrolytes. Continued monitoring of hydration and electrolyte balance is crucial, especially in the first 24 to 48 hours after surgery. 3, observation for complications. The medical team will watch for any signs of complications such as infection at the incision site or any issues with feeding or digestion. 4, pain management. Mild pain relief may be provided and the baby's monitored for comfort and well-being. 5, follow-up. A follow visit is typically scheduled to ensure that the baby is healing well and that feeding is progressing normally. Overall, with proper post-operative care, most babies recover quickly and without any long-term issues. If you have any other questions or need more details, just let me know.
Okay, what about differential diagnosis?
Great question. When considering the differential diagnosis for infantile hypertrophic pyloric stenosis, it's important to distinguish it from other causes of non-bilious vomiting in infants. Some key conditions to consider include one, gastroesophageal reflux or GERD, the skin cause vomiting as well, but it's usually less forceful and often associated with other symptoms like irritability or feeding difficulties. Two, gastroenteritis, viral or bacterial infections can lead to vomiting, but these are often accompanied by diarrhea, fever, and other signs of infection. House milk protein allergy, this can lead to vomiting and irritability, and it's often associated with blood in the stool or other allergic symptoms. For intestinal malrotation with midgut volvulus, this is a more urgent condition that can present with bilious vomiting and requires immediate attention, but it's important to rule it out if there's any concern. Five, pyloric spasm. This can cause intermittent vomiting due to spasms in the pyloric region, but it's generally less severe and less progressive than hypertrophic pyloric stenosis. By carefully assessing the clinical presentation and using imaging like ultrasound, doctors can pinpoint pyloric stenosis and differentiate it from these other conditions. If you need more details or have any other questions, just let me know.
Okay, thank you.
You're very welcome. If you have any more questions in the future, just let me know. Happy to help anytime.
Thank you for helping me.
It's my pleasure. I'm glad I could help. Don't hesitate to reach out anytime you need assistance. Have a wonderful day.
Okay, what's your name?
You can just call me ChatGPT, but if you'd like to give me a nickname, I'm totally fine with that as well, whatever you prefer.
Okay, thank you.
You're welcome anytime. If there's anything else you need, just let me know. Have a great one.
Thank you.